May I request everyone ದಯವಿಟ್ಟು ಮ್ಯೂಟ್ ಮಾಡ್ಕೊಳ್ಬೇಕು. So I request everyone to mute yourself except our obviously two presenters and examiners. Examiner agi Dr. I'm very happy that Dr. G.N. Prabhakar, Dr. Mohan and Dr. Chandrashekar. Thank you very much for consenting to be the examiners and moderator, Dr. Vidyadhar Kinhal. I think every one of you know that he is the past chairman, principal, HOD, Government Medical College Ballari, and my immediate 1 year senior. Extremely happy to be associated in this, and you've been supporting our all activities. I also welcome here our EC members, national as well as our state EC, and of course Dr. Shivaram, you are there also here, physically present here. And without wasting much time, later of course our secretary will tell it again at the end. So without wasting much time, can I hand over this to moderator Dr. Vidyadhar Kinhal? Please call one of the candidates, and that's how we'll start with. And handing over to Vidyadhar and examiners. Martin, please cooperate and coordinate. Thank you.
Thank you, sir. Thank you very much.
Good evening, everybody. It is a great occasion for me to be back as moderator for the PG examination that is being conducted by Kscasi under the dynamic leadership of Dr. Rajgopal Shenoy. It will be of great help to all the post-graduate students, and we have panel of examiners who are very, very seniors and have been well trained how to conduct examinations and how to find out the level of our PG students. I welcome the panel of examiners and also all the EC members. Let the student start his presentation. I think I will take permission from other three and then shall him start. Shall I request him to start? Yeah.
Yes, yes.
Chandru?
Yes, sir.
Yeah.
Yes, sir.
Prabhakar?
Yes, sir.
Prabhakar,
Yes,
yeah.
sir.
Nikhilesh? Who is the
Sir,
presenter?
good evening, sir. Sir,
Yeah.
me, sir.
Yeah, start your presentation.
Yes, sir. Sir, is the screen visible, sir?
Yeah, I am able to see you.
Sir, the PPT, sir. Yes, sir. Good evening, respected faculty. I'm
Make it
Dr.
full screen.
Nikhilesh, postgraduate. Yes, sir. Good evening, respected faculty members. I'm Dr. Nikhilesh, postgraduate from the Department of General Surgery from Sapthagiri Institute of Medical Science, Bangalore. My case presentation for today is case of mass per abdomen. Next slide. 62-year-old male gentleman hailing from Bangalore with an education of 12th standard, a security guard by occupation belonging to the middle class according to modified Gurubasavana scale, presented with the chief complaints of pain abdomen since 14 days, abdominal fullness since 10 days, and complaints of increased frequency in micturition since 10 days. Next slide. Next slide. Next slide. Patient was apparently normal 14 days back, after which he developed diffuse abdominal pain, which was insidious in onset and gradually progressive in nature, dull aching type, non-radiating, continuous type of pain, which was not associated with any aggravating factors or relieving factors. Patient also complains of diffuse abdominal fullness since 10 days, which was insidious in onset and gradually progressive. It was not associated with any aggravating or relieving factors. Next slide. Patient also complains of increased frequency of micturition since the past 10 days, which was insidious in onset and gradually progressive. Initially, patient gives history of passing urine 3 to 4 times a day. Currently, patient passes urine 8 to 9 times a day. It was not associated with difficulty in passing urine, burning sensation, hesitancy, urgency, nocturnal enuresis, or nocturia. Next slide. No history of vomiting, no history of loose stools, no history of constipation. There's no history of fever, no history of yellowish discoloration of the eyes or the urine, no history of loss of appetite, no history of trauma, no history of swelling elsewhere, and no history of weight loss. Patient is a known case of hypertension since 10 years and is on medication amlodipine 5 mg single dose per day. Is not a known case of diabetes, asthma, epilepsy, ischemic heart disease, or tuberculosis. There is no past surgical history. Family history, next slide. Family history, no history of similar complaints in the family. So next slide, sir. Next slide. Personal history, diet is mixed, appetite is normal, bowel habituated, bladder is previously regular. Now patient gives history of increased frequency of micturition. Sleep is adequate and there are no ill habits. Next slide. General physical examination. Patient is moderately built and nourished, well oriented to time, place, and person. With a body mass index of 24.2, there is no pallor, icterus, cyanosis, clubbing, edema, or generalized lymphadenopathy. Pulse rate at the time of examination was 80 beats per minute. Blood pressure 130 by 90 millimeters of mercury. Respiratory rate was 16 cycles per minute. Saturation 98% at room air. And temperature was afebrile. Karnofsky's performance score of the patient was 80. Next slide. This was the clinical photos of the patient.
Can we take few questions
Yes,
on history?
Yes, sir.
Kinhal, sir?
Yeah. Yes. Go ahead. You can ask questions. No problem. Oh, from the history that he has presented, Chandra,
Yes,
you can
sir.
ask questions.
Nikhil, what do you conclude with the history? Is
Sir,
there any going to get with the history, present history?
Sir, I cannot come to an absolute conclusion based on the history alone because of his vague abdominal pain and fullness and his chief complaints of increased frequency of micturition.
Was
At
there
the
any
current-
specific site, like upper abdomen or right abdomen or
Sir,
lower abdomen?
pain was diffuse in nature, sir. It was not localized to any of the quadrants, sir.
All over the abdomen.
Yes, sir.
One more thing, Nikhil, we have mentioned
Yes, sir.
insidious in all the symptoms.
Yes,
What
sir.
exactly in the insidious?
Sir, patient noticed the pain in a gradual manner. Initially, it was of low intensity. Gradually, it progressed
So what
in an
exactly the
insidious
meaning of
manner.
insidious? Insidious means subtle, hidden, something like that, which is not noticed. Pain is a sensation, so pain cannot be insidious.
Yes, sir.
So once the patient notices pain, exactly he can tell that when he has started noticing the pain. So it has progressed, what are the associated
Yes, sir.
symptoms. So we cannot tell pain as an insidious in onset. So, am I right, sir?
Okay.
Kinhal, sir?
Not only that, his history presentation doesn't point out to any system except some urinary changes. So I don't think he can offer any of the provisional diagnosis or whatever system that is abnormal. At present he cannot. Only thing is pain. He has to describe insidious lower in onset. Okay, let us consider as an examiner. I'll consider the insidious also as PG can present as insidious. I don't think you. You go ahead, my dear boy. Nikhilesh, you go ahead.
Yes, sir. Can I move on to general physical examination? Local examination. Systemic examination, perabdominal examination, inspection. Abdomen is distended, umbilicus is everted. Fullness is noted in the left hypochondrium and left lumbar region. Corresponding quadrants moves equally with respiration. 1 × 1 centimeter swelling is noted over the umbilicus and cough impulse is noted over it. There are no scars, dilated veins, striae, visible gastric or intestinal peristalsis, and there's no renal angle fullness noted. Next slide. On palpation, tenderness was present over the left hypochondrium and left lumbar region. All inspectory findings were confirmed. A diffuse swelling of 10 × 7 centimeter present superiorly extending from 2 centimeter below the left costal margin at anterior axillary line up to inferiorly 1 centimeter above the iliac crest. Laterally, it is extending up to the flanks and medially left costal margin at mid-clavicular line. There is no guarding or rigidity. Next slide. Surface of the swelling is smooth. It is variable in consistency and moves with respiration. Swelling is mobile. It does not fall forward on knee elbow position or on right lateral position. It is not ballotable and not pulsatile. Next slide. There is no hepatomegaly. Upper border of liver dullness is in 5th intercostal space and mid-clavicular line and lower border at the right costal margin. There is no splenomegaly. There is no renal angle tenderness or any palpable mass in the renal angle. A 1 × 1 centimeter swelling present over the umbilicus, reducible, cough impulse present and non-tender. Other hernial orifices are intact. Next slide. On percussion, there is no free fluid, no shifting dullness. Impaired note is present over the mass in the left hypochondrium and left lumbar region. On auscultation, bowel sounds are present. Next slide. On examination of the penis and testis, penis is central, ureteral meatus is normal, and both the testes are normal. Rectal examination. Next slide. External skin is normal, sphincter tone is normal, internal mucosa is normal. There is no palpable mass. Next slide. examination of the lymph nodes, left supraclavicular fossa, there was no palpable lymph nodes or swelling noted. And inguinal group of lymph nodes were non-palpable. Next slide. Systemic examination, cardiovascular system, S1 and S2 are normal. There is no murmur. Central nervous system, no neurological deficits were noted. Respiratory system, bilateral vesicular breath sounds were heard. Air entry was equal. Next slide. I would like to summarize my case. 62-year-old gentleman presenting with diffuse abdominal pain and fullness since 2 weeks without any history of rapid increase in size. It was associated with continuous non-radiating dull aching type of pain associated with increased frequency of micturition. It was not associated with burning sensation or pain during micturition with no history of other constitutional symptoms. On examination, general survey is normal. Local examination of the abdomen, tenderness is present and diffuse swelling of 10 cross 7 centimeter present superiorly extending from 2 centimeter below left costal margin at anterior axillary line, inferiorly up to the upper margin of the left iliac fossa, laterally extending up to the flanks and medially up to left costal margin at mid-clavicular line. Lump is variable in consistency, retroperitoneal, non-ballotable with impaired note on percussion. Based on this, I'd like to place my diagnosis as mass per abdomen of retroperitoneal origin. Retroperitoneal soft tissue tumor would likely be my first primary diagnosis, followed by a retroperitoneal cyst.
Okay, on the inspection, the swelling was confined to the left, this thing, or you are seeing the diffuse mass? Any mass?
Sir, sir, diffuse mass is appreciable on inspection, sir.
So you are not, I mean, is it a fullness or a mass?
Sir, it is on inspection fullness, sir.
Fullness.
Yes, sir.
You said all the corresponding quadrants moves equally with respiration.
Yes, sir.
So even the flanks, I mean, the flanks also moves equally with respiration. That is there.
Yes, sir. They move equally with respiration. There is no variation in the quadrants noted, sir.
What was the consistency on palpation?
Sir, it was variable in consistency, sir.
So upper border you can make out.
Yes, sir. Upper border can be made out, sir. It is 2 centimeter below the left costal margin at anterior axillary line.
But why
and
is
lower
it
border
moving
was
with
also.
respiration? But why is it moving with respiration if the upper border is also well felt?
Yes, sir.
No, see, any abdominal mass, why they move with respiration?
Sir, because of the attachment to the diaphragm, sir. Yes. On inspiration, it moves with respiration.
So if we are here, is there any relation to the diaphragm in this mass? Then why it moves with respiration?
Sometimes very large swellings can move with respiration, sir.
A retroperitoneal mass crosses midline or it doesn't cross midline?
Sir, it depends on the organ of involvement, sir. Intraperitoneal, if it is arising from the spleen, it can cross the midline.
No. Sir is asking retroperitoneal mass.
Retroperitoneal mass can also cross the midline, sir.
It will cross.
The importance of medial border.
Yes, sir.
The medial
Yes,
border
sir.
is clearly made out or not. If it is made out, whether it is crossing the midline,
Yes, sir.
it is a question. See,
Yes,
retroperitoneal,
sir.
don't expect that to cross midline.
Yes, sir.
What are the types of ballotabilities you know of?
Sir, organs which are ballotable are kidneys, sir. And then your fetal head in women, sir. Pregnant women, the head of the fetus is also ballotable, sir. And then
One small suggestion, Nikhilesh. Wherever you have
yes,
used lump word, you make it as mass.
yes, sir.
Swelling.
Abdominal
Okay.
masses, we don't think.
Swelling also.
Swelling also and
Yes,
lump
sir.
also. It is better that we use mass. Normally we use
Yes,
that.
sir.
However, we
Yes,
have
sir.
understood what you want to present. But palatability, there is one called as renal palatability and non-renal palatability. What it is?
Yes, sir. The renal palatability pertains to the kidneys, sir. Non-renal palatability, sir, like when huge masses cannot, yeah, like large masses, they can be palatable, sir, which are not arising from the kidneys. And then in fetal head is also palatable, sir. Palatability is checked in pregnant women, sir.
Okay. Yes, Prabhakar?
Yeah. Go ahead.
Mohan sir, ಕಾಣ್ತಾ ಇಲ್ಲ. Mohan sir? Okay. Prabhakar, you tell.
So,
Yeah.
you said there is no splenomegaly.
Yes, sir.
So, how did you say it is? It's not a spleen.
Sir, I was able to hook my fingers underneath the costal margin, sir.
Because it moves with respiration. No, why do you think it is splenomegaly or intraperitoneal? This thing.
Yes.
Why you are not thinking in terms of intraperitoneal?
Sir, intraperitoneal.
You have done already one examination there. You
Yes,
did one test also. What is it?
Sir, it is not falling forward on knee elbow position or right lateral position, sir.
You put him into knee elbow position, is it?
Yes, sir.
The recent clinical methods you have read, Rajgopal Shenoy, what
Yes,
he has
sir.
written. Okay, go ahead.
It does not fall for. Yes, sir. There is no hepatomegaly. Upper
Sir,
border of.
Mohan sir is there, I think.
Yeah, now
Now I am able to see. Now I am able to see him. Namaskara, sir. Mohan sir, namaskara.
Namaskara to everybody. Good
Yes,
evening,
sir.
Dr. Vidyadhar, Dr. Prabhakar, Dr.
Yeah.
Chandrashekar, everybody. Thank you, Dr. Rajgopal. Thank you.
Chandru, take over.
Yes, sir. Continue, man.
Yes, sir. There is no hepatomegaly.
What
Upper border of liver.
What is your impression now, finally?
Sir, my impression is mass per abdomen of retroperitoneal origin. My primary diagnosis is retroperitoneal soft tissue tumor. I would also like to include a retroperitoneal cyst as my secondary diagnosis, sir.
So anatomical position is retroperitoneal. Pathology
Yes,
is
sir.
yeah. So what are your points in favor of to call it as retroperitoneal? Enlist them.
Sir, on palpation, it is not falling forward, sir, on knee elbow position or on left lateral position.
Okay.
And
Which retroperitoneal tumor moves with respiration?
sir, sir, kidneys also move with respiration, sir.
This question is very specific.
Renal cell carcinoma.
Can you give clinically renal cell carcinoma?
No, sir. No, sir, we can't. Renal malignancy. Renal tumors.
Renal enlargement.
Renal enlargement. Yes.
So now your presentation is there is a mass in the abdomen which is in the retroperitoneal status. At present we do not know the pathology. The investigations will tell us what pathology it is. See,
How do you plan for your investigations?
Sir, I would like to get a diagnostic investigation, a routine investigation, sir. Routine investigations, I would like to get a routine panel done for the patient. For my to confirm my diagnosis, I'd like to get a CCTI abdomen and pelvis scan done, sir.
Ultrasound will not tell you anything?
Sir, ultrasound is an extension of our clinical findings, sir. But for my confirmatory diagnosis, I would like a CCT abdomen and pelvis, sir.
So you start off with CCT abdomen or ultrasound first?
I would get an ultrasound of the abdomen and pelvis, sir. Then I would move forward with the CCT abdomen pelvis.
Have you got the ultrasound done for this patient?
Yes, sir. We had gotten an ultrasound and a CCT scan done, sir.
What is the ultrasound finding you have seen there?
Yes, sir. Sir, ultrasound features, sir, just a second, sir.
Pardon?
Sir,
Ultrasound?
sir, ultrasound
Don't
features.
read that. Is it
Sir,
solid in
ultrasound, it was
consistency?
features. No, sir, ultrasound features suggestive of a cystic consistency, sir. 1x5, 2x2 centimeter cystic collection noted in the intra-abdominal, sir. It was ultrasound was not able to differentiate if it was intra-abdominal or retroperitoneal, sir.
Oh my God. Fantastic. How can it be possible? It is possible. I am a sonologist basically. I have worked. It is possible. Man.
Able to
You
give
say moves with
anatomical origin.
respiration.
Anatomical origin, where exactly from which structure it is.
You say it moves with respiration. Can you not make out?
Yeah, we can make
Is it from rectus abdominis? Is it from
No,
rectus
sir.
abdominis muscle? No. So it is not in
No,
varieties.
sir. No,
It
sir.
moves with respiration.
Yes,
What
sir.
is it? Ecotexture, man. Forget about the plane. Let us discuss plane later. What is it? Ecotexture.
Sir, well-defined homogeneous.
That is not ultrasound terminology. Homogeneous means what? Echogenic or echopoor? Cystic, mixed, tessellations, branches.
Sir, cystic, sir.
Cystic consistency. Is it vascular?
Sir, it's not vascular, sir.
How did you make out?
Sir, in ultrasound, it was not mentioned as vascularity, sir. Ultrasound, it was written as hypoechoic
mass. Did
Yes,
they put on the switch on the Doppler button? You will know whether there is blood inside or not.
Yes. We will get to know,
mix it up
sir.
with Doppler.
We can, yes, sir.
It is totally cystic, or there are multiple septa inside.
No septation, sir.
A single cyst it is, whole of it.
Yes, yes, sir. Sir, in USG, it was given as such, sir.
Single cyst.
Yes, sir.
Single cyst it is. And
sir, in ultrasound, yes, sir. Ultrasound was not done in our hospital, sir. It was done from a primary health center. Yes,
don't bother about it. Let it be done anywhere.
Yes,
but you must know what are its contents at least. Echogenic, echopoor, isoechoic.
Sir, hypoechoic collection without any internal septations, sir.
Okay. So there is a single cyst.
Yes, sir.
And so it is not isoechoic.
No, sir.
What is isoechoic? To call it as hypoechoic or hyperechoic, you must know isoechoic. Is it not?
Yes, sir.
Isoechoic means liver, normal liver. Okay. Go ahead. You have done an ultrasound. There is a cystic consistency mass. There is a mass
sir.
which contains only fluid with no septae. There is a single cyst. Is it not?
Yes, sir.
Okay. Go ahead with your CT.
Sir, CT scan, we got CCT abdomen and pelvis, which showed a large, well-defined, homogeneous hypodense lesion in the retroperitoneal region, posterior pararenal space in left posterior lateral aspect of the abdomen. A thin rim of mild enhancement is seen in the post-contrast image. The perilesional planes are relatively normal, and the lesion itself measures 15 cross 15 cross 20 centimeters, sir. Impression, retroperitoneal cyst in the left posterior pararenal space with extent as described above, seen in close proximity with the left renal vessels, sir. And as described above, with recommended HP correlation.
Any correlation to abdominal aorta? Since it is so big?
Sir, no, sir, not extending up to the abdominal aorta, sir. Posteriorly, the lesion is seen abutting the left psoas muscle, which is flattened by the cyst with loss of fat planes. Posteromedially, abdominal aorta and left diaphragmatic cura is seen with maintained fat planes, sir. Anteromedially, the left renal artery and renal vein is seen normal, sir. The left renal artery is seen in its entire length along the anteromedial wall of the cyst with no visible, yes, sir.
This mass is
Loss of
posterior to
fat.
the renal, this mass is posterior to renal artery.
Yes, sir.
Acha, acha, acha. So that means it must be posterior to abdominal aorta also.
Yes, sir. Yes, sir. Posterior-medially, sir, no, sir. It is in front of the aorta, sir.
And it is
Yes,
no, 1 minute, 1 minute. It is in front of
yes,
the
sir.
aorta, very good. But it is behind the
Yes,
renal
sir.
artery.
Yes, sir.
Behind the renal artery. Now you have to imagine an anatomy.
Anterior-medial. Yes, sir.
And you say that upper border is nicely seen even with CT as well as abdominal ultrasound. What makes it to
Yes,
move
sir.
with the respiration, man?
Sir,
No, I was giving it that clinically it may not be possible because the upper border may be abutting the diaphragm. Now you have done
Yes,
your
sir.
CT as well as ultrasound. It doesn't say that the upper border is anywhere nearer the diaphragm. Is it not?
No, it doesn't say, sir. Yes, sir.
Now you are stuck, man. What is your diagnosis then?
Sir, based on my CCT findings, my diagnosis is retroperitoneal cyst, sir.
Retroperitoneal cyst differentially? What do you call it? ಏನಪ್ಪಾ
What?
ಚಂದ್ರು ನೀನ್ ಮಾತಾಡು.
Yes, yes. What cyst you can expect? Retroperitoneal.
Sir, mucinous cyst adenoma, sir. Mucinous cyst adenoma of benign origin, sir.
Can you get a
No
retroperitoneal
problem.
mesenteric cyst?
Excuse me, sir.
Can you
I
get a
didn't get your question.
retroperitoneal mesenteric cyst?
Yes, sir. Retroperitoneal mesenteric cyst. We can get chylolymphatic cyst can also be seen, sir.
Then what
And
else?
sir, in case of trauma, hemorrhagic cyst can also be there, sir. Or in very rare cases, there can be parasitic hydatid cyst in the retroperitoneum.
Lymphangiomas?
Yes, sir. Lymphangiomas. Yes, sir. Chylolymphatic cyst can be seen, sir. And
No, actually, your clinical findings and the CT findings are not correlating. No, actually, you said variable in consistency, and here it is
yes, sir.
homogeneous cystic
Yes.
this thing.
Cystic inconsistency, sir.
Is it pulsatile?
Non-pulsatile, sir.
Mohan sir wants to ask something. Mohan
Yeah.
sir.
Dr. Vidyadhar, am I audible?
Yes,
Yeah,
sir.
yes,
Yeah, sure. You are
Yeah,
audible, sir.
There are 2 points. One is that he said the upper border is very well felt and it moves with respiration. There seem to be contradictory findings.
Yes, exactly. Yeah.
Second is the consistency, he said, is variable. So I don't know whether that again was a proper finding or whether it is a mistake. The third thing is I just want the opinion of the examiners also. This knee-elbow position is something which is outdated. I know many people don't accept
Yes,
that.
yes.
And it's uncomfortable
already-
for the patient.
It has already come in clinical examination books that knee elbow position is not indicated. Contraindicated
indicated.
now for the exam. Yeah.
Correct.
It's not indicated.
So therefore, my suggestion to the student is that it may not be required. In case the examiner asks, you can say that it is not done or something like that. Because usually it is not acceptable to put the patient into a knee elbow position. That's my point. Please go ahead, Dr.
It is well taken. Yeah, it is well taken. Knee elbow position is not allowed now. Okay.
Correct.
All our clinical examination should be as much little trouble to the patient as possible for the examination.
Correct.
Okay. And now you proceed with your, how will you proceed with this case? We have accepted as retroperitoneal cyst. That's all. We do not know the pathology of that retro. What you will do?
Sir, I would like
Yes,
to do, I would like to do an exploratory laparotomy and cyst excision. I would like to do a cyst excision, sir, because CT-guided biopsy is not indicated for a retroperitoneal cyst, sir. So I would like to do an exploratory laparotomy followed by cyst excision and subjecting that specimen to histopathology, sir.
Exploratory laparotomies are outdated indications for surgery now. You put a knife knowing the diagnosis. There is nothing like trying to know that. You can do the investigations, not cutting the patient, but you can get all the information without cutting. But exploratory laparotomy is not accepted as a norm of surgery now. Anything else you would like to do?
Yes. Sir, retroperitoneoscopy can also be done, sir.
Can you
That
aspirate? Can you aspirate that cyst?
You said it's
There are chances
contraindicated.
of, yes, sir. There is chances of rupture and spillage. So, and so I would not like to do a.
On CT, are they looking at malignancy, or do they think it's a benign cyst on CT?
On CT. The probable benign origin, but HPE correlation was required, sir.
In the cyst, is there any soft tissue projection into the cyst?
Solidly.
There is no,
Sorry,
no,
the
sir.
soft tissue.
No, sir. There is no projection. It is a 15 cross 15 cross 20 centimeter.
Totally
cyst
cystic
with,
in consistency.
totally cystic in
consistency. Why don't you use
consistency.
your ultrasound? Why don't you use your ultrasound equipment and try to do something? Put something inside that cyst. Anyhow, you are not suspecting malignancy now.
Correct.
Yes. We can, a pigtail catheter can be put, sir.
But you have one more this thing. Is it not possible to put your needle posteriorly, not through the peritoneum? Where the spill is there?
Yes, sir.
Peritoneum, yes, you can. So
Yes.
now it's such a big one. Under the ultrasound transducer guidance, you can definitely go into the cyst from posterior.
Yes, sir.
FNAC
We
is
can
definitely.
do a FNAC.
And needle
And
Yes.
not absolutely contraindication, because retroperitoneal is a space where you don't have roomy
Vital
space
structures.
where it can get ruptured. No, that
Yes.
doesn't happen like that. So there is no absolute contraindication for you to aspirate the retroperitoneal cyst, right, sir?
to add
Yes.
one more sentence to Chandru, there is absolutely no absolute contraindication for needle biopsies, FNACs anywhere in body now.
Yes.
Including parotid, you can go ahead. Including parotid, including thyroid, you can go ahead with FNAC. The
Yeah.
concept of it
Yes,
getting spillage is almost getting outdated now. You can definitely put a needle from posterior if you are suspecting that.
Yes, sir.
Is there any laparoscope available in your institution?
Yes, sir. We
Okay, you have done
can plan.
FNA.
Yes, sir.
You have done FNAC. The report comes as
Yes.
what?
Sir, it can come as a mucinous adenoma, sir, or
Mucinous cystadenoma is a from where? Mucinous cystadenoma.
From which
who is
organ?
its-
sir, pancreas, sir.
That means it's a
Or there can
pseudopancreatic
be,
cyst or cyst.
Mucinous cyst
no, sir. Pluripotent mesothelial cells deposits that can also cause mucinous adenoma, sir. A small percentage can occur from pancreas or even from the appendix also, sir.
Appendix is too far to think about because the position of the location is set.
It's
Yes,
on the left side now.
yes, sir. It's on the left side, sir.
So if we have allowed you to do surgery, what
Yes,
is the
sir.
incision you would like to take?
Midline laparotomy incision, sir.
Why not a
Midline
retroperitoneal approach? Why not a retroperitoneal approach? Because you know it's
The
benign.
chances, yes, sir.
Go ahead.
Chances of incisional lumbar hernias are higher, sir. So I would like to avoid that and go ahead with midline laparotomy incision.
You have seen how many incisional hernias so far?
Sir, we have seen, sir, in our institutions, we have seen and treated lumbar incisional hernias, sir.
Lumbar hernias you have been treating. Okay.
Yes, sir.
But now, what are all the differential diagnosis when asked for? Because we have skipped that heading.
Sir, retroperitoneal tumors, I would like to give my differential based on its benign or malignant nature. Sir, benign, it can be a lipoma, a neurofibroma, a leiomyoma, paraganglioma or a mucinous adenoma, whereas in malignancy, it can be a liposarcoma, leiomyosarcoma, malignant peripheral nerve sheath tumors, or in very rare cases of retroperitoneal lymph, secondaries in the retroperitoneal lymph nodes.
Many a times what happens in the examinations, last 2-3 minutes of examination, this will be asked to know what else you have read. But so far your presentation has been good, except 1 or 2. Lump uses for abdomen, lump you are not supposed to use. On one finding, all 4 of us have not agreed is moves with respiration. Because whole of the upper border is free. And what makes this retroperitoneal cyst to come down? And another thing is, you said renal artery is, it is posterior to renal artery and in front of the abdominal aorta. That doesn't fit in nicely because it has to go through the retroperitoneal fascia.
Yes, sir.
To come in front of the renal artery, to go posterior to renal artery, it should cross the fascia. That's something difficult. Retroperitoneum, this thing you have seen how strong it will be, retroperitoneal.
Yes.
And in general, presentation has been good. You have prepared well.
Yes.
We congratulate you
Thank
for
you.
having presented a very nice case. I think anybody would like to ask, please ask him questions.
I think in an abdominal mass, can I speak, Dr. Vidyadhar?
Yeah.
Yeah, sir. Go ahead,
Yeah.
sir. Go ahead, sir.
It is always a good idea to have a differential diagnosis because sometimes the student gets biased by the ultrasound finding or the CT finding. And therefore, it is the examiner wants to know whether you have thought of other things as well. Because don't be misled
Yes,
by
sir.
the CT or the ultrasound report. Don't go only by that.
Yeah.
You should
Yes, sir.
have your own thinking and don't get biased by the reports. That's my point. You should have a differential in an abdominal mass always.
Sir, my differentials for an abdominal mass, I would like to base
I'm
my
saying
primary on a. Yes,
in general, not only in this case, in general.
yes, sir.
No, continue with Ellen Wansworth's whatever he said. See, basically what happened, you cannot go inside the abdomen and see what exactly the thing. You have to combine your history findings with the examination findings, put a diagnosis, which is the anatomical origin of the mass, and what is the pathology, whether it is benign or malignant. So combine these two, anatomy as well as the pathology, you will come to few of the differential diagnosis. Based on that, you can proceed with your investigation and treatment aspect. So that will be the mode of evaluation, what happens in the post-graduation examination.
One more small suggestion is all postgraduates should know how to do an ultrasound. Because in casualty, we are keeping ultrasound machine always now. We must be able to see and decipher the findings of ultrasound. You must learn, go to the radiology department and learn a bit of ultrasound. And these are the times wherein you can see without cutting. This is the present scenario. Earlier, we used to see laparotomy and proceed. No more laparotomy and proceed, please. Okay, Prabhakar.
Yeah, I think the history was good and examination little findings were not in this. Otherwise, the presentation was good. Yeah, clinical diagnosis, it's a bit difficult in this case, in such cases like this. But as Chandru said, you have to give some differential diagnosis. So otherwise, its presentation is good, no problem.
For completion sake, I think you can also add MRI for that. For completion sake, it may give us some extra information.
How does it help?
Sir,
That's what I'm asking,
retroperitoneal.
Nikhilesh.
Sir, I didn't get your question, sir.
Role of MRI in a retroperitoneal tumor.
Sir, MRI. Sir,
What extra information you are going to get apart from CT? That is what the question from Vidyadhar, sir.
Sir, we can get to know the vascular invasion, sir. Extension or encasement of extension or encasement
Muscles,
of the
muscle
aorta. And
You have to see the
differentiation.
muscle, man. You said it is sitting on the rectus
Yes,
muscle.
sir.
I mean, sorry, psoas muscle.
Psoas muscle.
Psoas
You
muscle.
must know
Yes, sir.
that. And of course, you are having doubts regarding renal artery and abdominal aorta. That also you can make out very easily. But I also add Doppler, man. Doppler will give you much more real-time information. Man. These are all recorded information. So you will get a real-time information on Doppler. Okay. Good.
Yes, sir.
Congratulations. Best of luck to you. Anybody
Thanks,
else
sir.
wants to ask question? You can ask them.
I just want to know whether you have examined the spine. Remember, always think of a cold abscess also when you have a
Yes, sir.
retroperitoneal soft tissue cystic lesion. I don't remember whether you spoke about spine examination. I can't recollect, but that is something which you need to look at or
He didn't
think
comment
of clinically.
No, I didn't comment on this fine, sir.
Right, you should. See, examination of the spine is part of abdominal examination. Not only the renal angles, also always examine the spine.
He
Tenderness,
mentioned
deformity,
per examination, did not mention spine.
spine. Spine is also important.
Yeah, important.
That's the only thing.
Yes.
Good presentation, Dr. Nikhilesh.
Thank you,
Comment
sir.
is possible. Comment. Srinivas
Yes.
bhai here.
Yeah.
A comment. Is it
So with-
allowed?
Yeah, of course.
Yeah, allowed.
And advice to the candidate. Try not to offer a diagnosis of cyst inside intra-abdominal cyst unless you have very good evidence. Okay. Unless you have a good
Yes, sir.
evidence, try to avoid the diagnosis of cyst in the exam. Intra-abdominal, because very difficult to tell it's a cyst or a solid. To tell the consistency, you yourself said variable consistency. If it was a cyst, it's a perfect circle or a perfect oval
Yes,
with the
sir.
correct consistency. One. Second one, the moment you feel the upper border, movement of the respiration won't be there if you're going to offer a retroperitoneal tumor as your diagnosis. It is not possible. Okay. Even the kidney, if you won't feel the upper border normally, because on either side the kidney goes behind other organs, so you won't be able to feel it, the upper border, even in the renal masses. Okay, the renal masses move with respiration,
Yes.
but then you won't feel the upper border. Okay, clear? Only a large retroperitoneal tumor will
Yes, sir.
move with respiration, provided you don't feel the upper border. Okay. And you
Yes, sir.
don't try to fit your diagnosis based on your radiology. Rather than that, put your, I mean, this is a discussion where the radiology is available to you. In the university exam, you won't get that benefit normally. So you will have to go with your clinical finding. Even if somebody comes and tells you, no, this is a cyst, don't tell it's a cyst. Tell it is retroperitoneal tumor only. And
Yes, sir.
biopsies can be done in all retroperitoneal tumors. That is the standard of care nowadays, okay? Because of the cables and the incidence of spillage reported from ever since we documented is 0%. It has not happened yet. It's only in our minds that spillage is occurring, okay? It doesn't
Yes, sir.
happen, okay? Because the core biopsy needles are coaxial. Okay, you can go and read up about it. What's a coaxial core biopsy needle?
Yes, sir.
Thank you, sir. Thank you, sir.
Thank you. So nice
Thank
of you. Thank
Thank
you.
you, Doctor.
And the investigations also don't straight away go to the CECT. Ultrasound is definitely will give much more information. Then you can plan for the CECT. Directly, I don't think it can jump to the CECT.
Third hand of surgeon is ultrasound transducer now. Okay, good.
Yes, sir.
Thank you. Thank you, Sarvesh. You take over and call the next candidate.
Thank you, sir.
Is charge ಆಗ್ತಾ ಇದೆಯಾ?
Sanjitha, you can share your slides.
Yes, sir. I'm sharing my.
Welcome, Sanjitha.
Sir, good evening, sir.
Introduce yourself.
Sir, good evening, everybody. I am Sanjitha, sir, currently a second year postgraduate from Department of General Surgery in Siddhartha Medical College, Tumkur, sir.
Okay.
Slides are visible. You can go ahead.
Yes, sir. Here is a 57-year-old female patient, resident of Kottatikere, a daily wage worker by occupation. presented with complaints of swelling in the lower part of the front of the neck noticed 6 months ago. Patient was apparently normal 6 months ago when she noticed a swelling in the lower part of the front of the neck, insidious in onset, gradually progressive in size, and initially the size of the marble and reached the current size of a small lemon, approximately 3 cross 4 centimeters. The swelling is not associated with pain, and patient does not give history of difficulty in breathing, difficulty in swallowing, or any change in voice. Patient does not give history of weight gain or loss, heat or cold intolerance, and also does not give history of diarrhea or constipation. She does not give history of tremors, muscle weakness, and insomnia. She does not give history of palpitations, chest pain, and ankle edema, and there is no history of bone pain or cough with hemoptysis. In the past history, she underwent tubectomy 25 years ago, and she does not give history of any known comorbidities. She does not give history of any drug intake or allergies or radiation exposure. In the personal history, her appetite is normal and she consumes a mixed diet. She has a normal sleep-wake cycle. Her bowel and bladder movements are regular, and she's a known Erica nut chewer since 3 years. She attained menarche at the age of 14 years and menopause at the age of 4 years ago. There is no significant family history. In general physical examination.
Okay, in the history, what is your conclusion?
Sir, from the location of the swelling, since it is present in the lower part of the front of the neck, and the most common swelling in that region could be a thyroid, I'm thinking it is a thyroid swelling. And she does not give any complaints of pain or rapid progression or any toxic symptoms. So I'm thinking it could be a thyroid swelling, which is a simple goiter.
Thyroid swelling, goiter is a medical terminology for thyroid swelling. Swelling of thyroid is called as goiter.
Goiter.
Yeah.
Yes, sir.
How many children she has?
Sir, she has 4 children, sir.
Is it important?
Yes, sir. Obstetric history could be important in case of thyroid patients, sir. They could have infertility or frequent abortions.
Yeah. Fine, go ahead. So you are swelling
Yes,
in
sir.
the middle of the neck, in front of the
Lower
neck?
part of the front of the neck, sir.
Okay.
With 6 months history,
Okay.
sir. She noticed it 6 months back, sir.
Okay.
Dr.
And
Sanjitha,
yes, sir.
sorry, is there any drug history? Did you talk about
Yes, sir.
medication?
She does not give any known drug history, sir.
Can you tell us which drugs can produce a goiter?
Sir, goitrogenic drugs, anti-thyroid drugs like carbimazole and propyluracil by themselves are goitrogenic, sir. If she's taking any psychiatric medications like
Correct.
lithium.
So, lithium.
Yeah.
So remember that. So you need to take that history as well.
Yes, sir.
Okay, go ahead. Go ahead.
On general physical examination, she's a 57-year-old female patient who is moderately built and nourished, conscious, cooperative, oriented to time, place, and person at the time of examination, and she appears comfortable. Her height is 162 centimeters with a weight of 55 kg, and her body mass index comes to be about 21 kilograms per square meter. Her pulse is 82 beats per minute at right radial artery with a regular rhythm and normal volume. Her BP is 130 by 90 millimeters of mercury in the right arm in a sitting position. Her respiratory rate is 18 cycles per minute and her saturation is 98% on room air. She does not show any signs of pallor, icterus, cyanosis, clubbing, edema, or lymphadenopathy. Coming to local examination, the patient is examined in sitting position, well exposed till the waist in a brightly lit room under natural light after taking consent. On inspection, a solitary vertically oval-shaped swelling on the lower part of the front of the neck towards the left of the midline, approximately 3 cross 4 centimeters in size is noted. It is extending superiorly till the thyroid cartilage and inferiorly 1 centimeter above the suprasternal notch. Medially, it crosses the midline and lateral border appears diffuse. The inferior border is visible on swallowing and the surface appears to be smooth. The swelling moves with deglutition and not with protrusion of the tongue. The trachea appears central in position. There are no visible dilated veins, no visible pulsations, and no other swellings noted. So this is the clinical image of the patient. We can see the deglutition test. On palpation, there is no local rise of temperature or tenderness. Inspectory findings were confirmed, and the extent superiorly till the thyroid cartilage, inferiorly 1 centimeters above the suprasternal notch. The lateral border is diffuse and medially it crosses the midline. It is soft in consistency with nodular surface. There is no fixity to the skin, and the trachea lies central in position. Carotid pulsations were felt in the normal positions, and no other swellings were palpable in the neck. On percussion, there is no retrosternal extent noted, and there is no bruit heard on auscultation. Her systemic examination, CVS S1, S2 are heard, CNS, no sensory motor deficits noted, and she has normal reflexes. Respiratory bilateral air entry was present with normal vascular breath sounds. Her perabdomen was soft, non-tender, no distension, and no organomegaly noted.
Yes.
Coming to the diagnosis, it could be a non-toxic multinodular goiter, sir.
Why multinodular?
Sir, on palpation, it appears to be nodular rather than smooth, which was on inspection, sir.
Go back to that palpation slide.
Yes, sir.
You've written inspectory findings are
Findings are
confirmed.
confirmed. That's all. You have now never told that there are,
Nodules.
surface is nodular.
Sir,
It says
soft
surface.
No. How did you elicit the consistency? How did you elicit consistency?
By
What is the prerequisite for examining consistency? Forget about thyroid. Everywhere, all over the body, there is swelling. What is the prerequisite for examination of consistency? Consistency means what? What I contain.
how it feels.
What I contain is consistency. How
Yes,
will you
sir.
make out?
Sir, if it feels similar to our ear lobule, we can say it is a soft swelling.
That is firm. Tip of the nose is firm. Is it not?
Ear
What
lobule,
I want
sir.
to know is if you are able to fix a swelling, you can elicit fluctuation.
Yes, sir.
If you are trying to move this nodule, it moves along with the trachea to that side. How will you know what it contains? You must be able, that is one of the reasons why you examine the thyroid from behind, wherein
Yes,
you can also fix the swelling because posteriorly you can push the mass to the vertebra, and then examination of the swelling can be done. That's one of the reasons why examine thyroid is examined from behind. Is this the reason for it? And now you say it is soft in consistency. Soft is not a terminology for consistency. One is firm, other is hard, other is cystic. What is this soft? What is soft for you is hard for me.
Yes, sir.
What is soft for you is hard for me. What will you do? Mohan sir wants to ask something. Yes, sir.
Yes. No, I think that word soft is a little dangerous when there is a patient with a thyroid swelling, because the thyroid is a very deep structure. It's not like a subcutaneous lipoma where you can use the word soft. So probably this is a firm swelling. I don't know why you have written soft there. That's what I would say. That's my comment.
Can uniformly soft swelling be nodular?
Very unlikely. Very unlikely.
Not only that, she has copied one sentence from Clinical Methods by Das. So you can't say no to her because that soft still exists in Das Clinical Methods. Though we have to pass it and she has read it. But however, soft in consistency, how do you elicit it is soft? What interprets you? Fluctuation present or absent?
Sir, it was absent, sir.
Displacement of fluid is fluctuation.
Yes, sir.
It is not possible. It is absent. Then how do you call it as soft?
Sir.
Next time you don't use the word soft, you get stuck in the examination. There is no need. Either you call it as firm, or you call it as fluctuant, cystic, or you call it as bony, hard. That's all. Okay.
And moreover, you said it's a nodular surface on palpation.
You are contradicting your first sentence to third sentence. There's a problem in that slide.
Yes,
Is it?
sir.
Okay.
You
Sir,
said
I have a
question.
Yeah,
Nodular
please.
the
surface
inspectory
must
findings
have
are
one
confirmed. Inspection, you
consistency.
said it was well. So suddenly you
Yeah.
came to nodular surface.
Sir,
Yeah, that's what Sunil Joshi is asking is the relevant question. Yeah.
Sir, I have a question. I want to know from Sanjitha, what does she mean when she says that on palpation, the lateral
Yes.
border is diffuse?
Sir, I can't feel the lateral border of the swelling clearly, sir.
And that is on palpation, you are saying?
Yes, sir.
No, it is actually diffuse is an inspector finding where lateral border is not visible.
Yes, sir.
Yeah. It goes behind the circulatory muscle. You can relax it and palpate and look
You
for the
can
lateral
palpate, still
border.
palpate.
And
Yes, sir.
on swallowing, you are able to see it. It is nicely seen. The lateral border is also seen. Deglutition, you are able
What
to
is
see.
the implication? What is the implication if it is diffuse? What do you infer?
If it is diffuse, how do you say the size of the swelling? All these things do don't worry about that.
Yes.
In general, you know that there is a swelling in the region of the thyroid. You are presenting it is nodular in nature. That's what you said. And we do not
Yes.
accept it as soft in consistency. It moves
Yes.
up with the deglutition. You should use the word, you should up with the deglutition. And she
Yes.
being around 52 years of age, trying to protrude the tongue and examination looks to be, may not be that relevant, but still you know that the physical finding has to be examined. Good, we appreciate you. The lateral border is also seen, lower border seen, upper border seen. What is your diagnosis? And now, of course, one more thing you must, that does it have any possibility of pulsation on that?
So no visible pulsations noted, sir.
No, you have completed palpation also, madam.
Palpation also completed, no? On palpation, did you get any pulsation?
No, sir. I could only feel the normal carotid pulsations, sir. No other
Okay.
pulsations noted, sir.
How do you examine a swelling for pulsations? You have done that, you must give this answer. You said it is non-pulsatile. What made you to think that it is not pulsatile?
Did you
Are you not
palpate
understanding?
against anything, any hard structure like that?
Are you not understanding my question?
Yes, sir. I can, sir.
What are the types of pulsations you know of?
Pulsations.
What are the types of pulsations you know of? I am sitting on my abdominal aorta, or I am an aneurysm. You tell me, what are the types of pulsations you know of?
Swelling
I-
above the artery or swelling arising from the artery?
I'm sitting. I'm not able to hear you properly. Okay?
Hello?
Is it?
Sanjitha,
Yes, sir. Yes, sir.
what type of pulsations you will get if the swelling is sitting over the vessel or if the vessel itself is giving rise to swelling?
I will add that. You expand your knowledge, you will get it.
Yes, sir.
Sir has given clue.
Clue.
I think it's given a clue also. What is
Expansile.
You can you can transmit that knowledge with expansion.
You've given the answer. So, Dr. Sanjitha, it is expansile and or transmitted.
Transmitted.
You are
Yes.
not answered yet my question. How do you look for a pulsation on a swelling?
Sir, we can feel for it against a hard surface.
Jarrat nahi, that is transmitted.
No, sir again wants to
You
know
must-
like different types of.
No,
what
what
are
I
the
want
types?
to tell is, don't do any examination during that time except for that 10 seconds. Keep your fingers only looking for pulsation. Otherwise, it is not possible. Only looking for pulsation. Keep your minimum 2 fingers of 2 hands or 2 fingers of 1 hand. But you must look only for pulsation, not Prui or something of that sort. You must keep your hand on the swelling, looking mind to be directed towards pulsation only. Then only you will. Otherwise, you will definitely miss this pulsation. Okay. And
Yes,
the
sir.
neck swellings, if you don't look for pulsation, it looks to be something difficult, And thyroid, vascular or avascular?
It is highly vascular organ, sir.
Highly vascular. In a multinodular goiter, The nodule is vascular or internodular tissue is vascular?
So the nodule is vascular, sir.
No, no.
Is the active
यार,
part of
ऐसा
the
नहीं हो
active
सकता
part
यार.
of the
See,
multinodular.
That is this
Madam,
internodular.
one thing you remember, I always give clue to my students so that I will get the answer. I have expansile transmission, I have already given you, I have answered you. Only thing is, if you know, you will pick it up. Now, what I am trying to tell you is, nodule is vascular or internodular tissue is vascular. समझने की कोशिश करो.
Which is the active part of the gland in the multinodular?
So the internodular tissue is the.
Correct.
So it has to be vascular now.
Yes, sir.
Now you tell me, what's your diagnosis? Okay, well, amma thyroid ಅಂದ್ರೆ ನಾ 2 ತಾಸು ವರೆಗೆ ಮುಗಿಸೋದಿಲ್ಲ ಬೇಡ ಜಲ್ದಿ ಹೇಳಿ what's your diagnosis?
It's a non-toxic multinodular goiter.
ನಂಗೆ ರಾಜಗೋಪಾಲ್ ಚೆನ್ನಾಗಿ ಹೇಳ don't cross more than the time ಅಂತ ಅಂದ್ಬೇಕು ಥೈರಾಯ್ಡ್ ಅಂದ್ಬಿಟ್ರೆ ಮುಗಿಯೋದೇ ಇಲ್ಲ ಅದಕ್ಕೆ ನಾನ್ ಟಾಕ್ಸಿಕ್
Multinodular goiter.
multinodular goiter. Okay, I've already told you why you examine the thyroid from behind. You understand? You just imagine a bucket with one table tennis ball. You try to hold it. What will happen to that ball?
It will keep slipping away.
It goes inside the bucket. You can't hold it. But you come from behind and then try to hold it. In the bucket only, you will be able to. So now you imagine that neck to be a bucket, a ball is thyroid gland. So you have to examine from behind to catch that fellow. You understand why you want to examine thyroid? Okay, now it is multinodular goiter. What will you do? Tell us the examination that you want, investigations you want to do.
Sir, apart from the routine investigations, I'll get one thyroid function test, sir. We can also get one USG neck.
Thyroid function test में क्या होता है? What will happen?
Sir, TSH, T3 and T4, sir.
Okay.
We can see if there is any alterations in the T3, T4 and relation of T3, T4 values and TSH, sir. If they're within the euthyroid state or if she's in hyperthyroid or hypothyroid states.
If the TSH is 20, what will you do? If the TSH is 20, what will you do?
What is your diagnosis?
What is the normal value?
What is normal TSH?
Please scribbling.
See, the normal value you should know.
Yes, sir.
But you just ordered. No, one thing you must always remember, all students, irrespective of MS General Surgery or any other student, when you order an investigation, you must know how to read that investigation. Otherwise, you have no right to order that investigation. You must know how to interpret that investigation. Before ordering, you must know about that investigation. Otherwise, why will you order? Now I'm telling you TSH is 20. What will you do?
20, is it normal?
Is TSH?
No, sir.
What is it?
What is normal?
This is not. आज घर में जाके पढ़ना है. If you do not know the normal values of T3, T4, TSH, what right you have got to order them? Is goiter or nodular swellings of thyroid reversible?
Sir, diffuse hyperplastic goiter is reversible. Sir.
No. Question is nodular. No, sir is asking nodular.
You should answer to the point.
If there is total thyroid gland enlargement, what do you suspect with TSH being 40?
Hypothyroid.
What type of hypothyroidism you get? C52?
Sir, it could be.
ನಾನು ಏನಾಗ್ತದೆ ಗೊತ್ತಾ? You come and read and come for the sake of surgical examination. That is a problem. There is also a medical component of thyroid. Who has to answer that? Surgery, you are ready now. Hemithyroidectomy, hysterectomy, total thyroidectomy, block dissection of neck, all these things you would have read are also assisted. But what about the medical component of it before she going into OT?
Yes, sir.
Okay, all right. We have done TSH. All the investigations are within normal limits for your luck. Yes, what else you want to do?
So we can get one USG of the neck, sir.
What will you find? What is the transducer that you use for USG? You have seen an USG of the neck being done?
Yes, sir.
You have seen the transducer? What is transducer? You tell me.
With what?
Transducer under
The probe with
good.
Ah.
Probe. Okay, very good, very good. So you've seen it being done?
Yes, sir.
Achha, very good. Then what is the interpretation you would like to see there?
Sir, we could see if it is a cystic or a solid swelling. We can see if it's
Or
a
both?
single or it's a
Both
combination
together.
of, yes, sir.
Yeah,
A
both
solid
together.
component within a cystic swelling.
Yeah, projection into the cavity. Okay.
We can see the number of swellings, and if we can see if there are any other lymph nodes involved other than the thyroid within the neck region.
Very good, very good. You can put on the Doppler. The Doppler,
Yes, sir.
this thing is also there only. What will it tell you? That nodule is vascular or not, will tell you.
Yes, sir.
If it is Doppler, definitely you'll be able to see the vessels inside the nodule. Is it not? Whether it is venous or arterial.
Yes, sir.
Or it may show only internodular tissue being extremely vascular. Will it not help you?
It will help us, sir.
Yeah. What will you do while doing that? It is cystic and there is an intracystic protrusion of soft tissue. Will you try to do something for that?
Sir, we can try to take needle aspiration cytology within the solid
Fine.
component on ultrasound guidance.
Yeah, ultrasound guided needle aspiration for the place where there is intracystic soft tissue projection.
Yes,
so, yeah. What's your diagnosis now? You have done the investigations, ultrasound you have done. Any other investigation you would like to do?
After ultrasound, we can also get one fine needle aspiration cytology, sir.
During that only we have already done ultrasound
Yes,
guided needle aspiration biopsy. Okay. Then
in this patient, other than those 3 investigations, it does not require further investigation in this patient, sir. We can, if we are planning for surgery, we can get one.
I am not planning for surgery. You have to plan.
You have to decide.
You have to plan. Okay, doesn't matter. Yes. What surgery you would like to do? Under what anesthesia?
I would go with total thyroidectomy under general anesthesia, sir.
Why total thyroidectomy with the report being benign?
Sir, given her age, though it is benign, there is a chance of recurrence later on, which would require a revision surgery. Rather than that, I would go for total thyroidectomy and give her lifelong thyroid supplementation, sir.
The other lobe is also palpable?
Not palpable, sir.
You never commented on the other lobe, nodularity.
What is the problem you face? Yeah, good. No, sir, good.
Only one point. For the student, I think it is better not to use the word USG in the exam.
Yeah.
You say ultrasonography because sometimes some examiners get irritated. During a normal conversation, you can say USG, but when you go for an exam, be careful of these words and sentences. Say that you will do an ultrasonography of the neck, not only the thyroid.
Yes, sir.
That's my comment.
You have assisted how many thyroids so far?
Sir, 5 thyroids, sir.
5 thyroids. You have seen a parathyroid on that?
No,
you have
sir.
seen the parathyroid gland on the table?
No, sir.
It is on the anterior surface or posterior surface?
Posterior surface, sir.
Achha. Where do you find that? What makes you to call it as parathyroid?
How do you differentiate between thyroid and parathyroid? In other words, sir is asking.
Sir, it's just adjacent to the thyroid gland and it looks like a fat globule, sir.
Good. What is the work? You must be careful about not using what dissection there.
What type of
what you should not use in the posterior dissection we are doing, where you are doing at the presence of parathyroid. As far as possible, you don't use a cautery so that it will damage the blood supply to the parathyroid. You understand? And you are doing a total thyroidectomy. If both the parathyroids are gone, what will happen?
She will land up in hypoparathyroidism.
Yeah. Any other complication that you know about total thyroidectomy?
One is reactionary hemorrhage post-surgery, sir.
Hey, people are very good surgeons nowadays. You don't find reaction. And we have a lot of gadgets which will not cause reaction. And
Injury
I have
to
only read it. I only read it during 1983 when I did my post-graduation. No reaction. Okay. Yes. Then.
injury to the recurrent laryngeal nerve.
Come out with that. Yes, that is possible. Because increased use of cautery nowadays, because it is easily available, causes a lot of
Lateral damage
neuropraxia.
to the, yes, sir.
Neuropraxia. So you must be careful during that place. And then any other complication that you know?
Injury to the superior laryngeal nerve, external branch of the superior laryngeal nerve.
What happens?
Patient will lose the pitch of her voice post-operatively.
Superior laryngeal nerve supplies what?
So the internal branch supplies the mucosa above the glottis, sir, whereas the external branch supplies the cricothyroid muscle.
Cricothyroid muscle is pierced by which nerve? Lata Mangeshkar will file a case against you. Now that is a clue for you.
External branch of the superior laryngeal nerve, sir.
Lata Mangeshkar, what she will lose?
Larynx. So she lose a pitch of her voice, sir.
ऐसा नहीं.
Tone.
Sustained pitch of voice.
Yes.
ಒಂದೇ ಸ್ಟ್ಯಾಂಜ ಹೇಳಕ್ಕಾಗುತ್ತೆ, ನೆಕ್ಸ್ಟ್ ಸ್ಟ್ಯಾಂಜ ಆಗಲ್ಲ. It gets tired because tensor facial, tensor of the vocal cord is that muscle which is piercing. So that is lost. So sustained tension is not possible over the vocal cord. That's why they will not be able to sing full 3 stanzas. She will file a case against it. Okay, yes. Then anything else you would like to comment upon regarding surgery? Timber of voice, Pai Srinivas says. Yes, it's correct. It's the right word he has used, timber of voice. In Chandru's student ಏನಪ್ಪ ಇವರು?
ಇಲ್ಲ, ನಮ್ಮ ಸ್ಟೂಡೆಂಟ್.
Prabhakar student. ಅದಕ್ಕೆ ಏನು ಪ್ರಶ್ನೆ ಕೇಳಿಲ್ಲ ಅದಕ್ಕೆ. You have done well. Prabhakar is training you so well. We are proud of Prabhakar that he has trained a good postgraduate student by name Sanjitha. I am extremely happy. Anything else you would like to say? The recent advances in thyroid surgery. I do not want to see any scar on the neck.
Sir, we can go through peroral axis, sir. Oral or axillary axis can be there in thyroid surgery.
Yeah. Peroral, there is one problem. There is one paper already that the infection rate on peroral surgery. Infection rate through peroral appears to be on higher side when compared to axillary.
Yes, sir.
But axillary, you must have higher learning curve is there for axillary. But peroral also there is higher curve. But
transmemory
upper thyroid.
also.
Yeah. Transmemory also.
Endoscopic thyroidectomy. But their own limitation. You can't do for large swellings. It's less than 4 centimeters, small.
Yes, Chandra.
For hemithyroidectomy. So those are the indications for endoscopic thyroidectomies.
Okay, she has done a very nice presentation. 1 or 2 small corrections here, and even if I present that, you will be objecting to me regarding this. And this happens that your presentation is good. You are a potential candidate to become surgeon in another 1 year, is it?
Yes, sir.
Yeah. Prabhakar Channa training Madapa, she has done well. I am very happy about it.
Actually, she's a good student. I don't know how she was. She's a bit nervous.
No, she's doing very well. Only thing is,
I think she's done well. I think she's
you have to remember one thing. Keep your ears open.
Yes, sir.
Most of the examiners will give you clues. He has come there to pass you, not to fail you.
The other thing is, I think she's come with a fixed diagnosis of multinodular goiter.
Correct.
Because she probably knows the ultrasound finding or the FNAC finding. So they are not able to think laterally. Remember that the examiner can ask you about malignancy, can ask you about other pathologies also.
Hypothyroidism.
Where is
hypothyroidism?
Hashimoto's could be asked.
Hashimoto's.
So therefore, keep your mind open. Don't go only by, as Sir said earlier, don't get biased by the ultrasound or radiological reports always. Because in the exam, they are free to ask you anything else.
Yes, sir.
Okay.
Only thing is, don't commit blunders. That I have examined femoral artery in neck. That's all. Everything will be taken care of by us. Don't commit a mistake of that kind. Okay. And pulsations, that was what I have given you a lot of clues for getting that answer from you. Remember that and go and read now. Pai wants to say something. Pai sir wants to say something.
No, what I'm saying is exactly what Professor Mohan was telling. That don't suit your diagnosis into your ultrasound findings.
Yes.
True.
Your ultrasound findings won't be given it to you in the exam. This is a common mistake we make. For here, it is okay because we're discussing the case. But you should be blind to your the investigations also. You understood what I'm trying to say?
Yes, sir.
Yeah. Second thing, why do you want to operate this patient? I don't see any reason. What is the reason to operate her? You said, no, you'll do total thyroidectomy. But you never told the examiners why you want to do a total thyroidectomy.
What is the indication in this lady?
Why do you want to operate her? Do you want to? You can leave her alone, or
She has
We
no
can-
symptoms.
Sanjitha, you
We
operate
can,
that
we
big
can leave
colloid
her.
goiter. Some young lady comes to you with the big colloid goiter. She wants surgery. So why you want to operate? One of the reason for one of the
So cosmesis could be one reason.
one of the indication is cosmetic. That's all.
But she
No, no,
does
no,
not
no.
have.
One of my colleagues' wife developed thyroid lymphoma.
Ah.
Yeah.
He died within 9 months. He died. Thyroid lymphoma. My neighbor, that doctor is. So that cannot be taken into account like this. Thyroid lymphoma is one of the definite indications for doing total thyroidectomy. Okay.
Yes.
And see, multinodular goiter trace for 10 years, 30% of them can turn malignant.
Yes, sir.
To answer Srinivas,
What type of
why, sir?
malignancy?
Sir, papillary
yeah,
thyroid
you answer.
carcinomas,
No.
No.
follicular, they usually follicular carcinomas.
Nowadays, the thyroid chapters contain only one surgery. That is total thyroidectomy. Because I don't want to step twice into a river. Khatam kar do usko. Or if there is an emergency, you can take out the isthmectomy to save the patient from the stridor. Otherwise, it is better that doing a total thyroidectomy, you are saving the patient of second surgery if sometimes it may occur. It may not be. But of late, for the last 3 years, I have been doing total thyroidectomy directly. First, I will give you thyroxine and then see how much of reduction of the size can occur. That's why I asked you if the TSH is 20, what will you do? Put her on thyroxine, the size comes down because there is what is called as extra parenchymal growth due to the demand by the TSH. So that will come down. The TSH level comes down, then you can take the patient for surgery. Okay. That is what I've been doing. But of course, you go through the textbooks and this soft is written only in clinical methods by Das. No other clinical methods, including Rajgopal Shenoy mentions. Okay. Thank you, everybody. And I thank the organizers, Ksci, Dr. Rajgopal Shenoy, Sarvesha, and all of them. EC members and central EC members, state EC members, I thank all of them. So nice it is. I enjoyed every minute here.
Same here, Dr. Vidyadhar. Nice talking to everybody. Wish students all the best in their exams. They've done a good job. Thank you so much.
Thank you.
Hello.
Thank you, sir. Thank you very much.
Thank you.
Hello. Can you hear me?
Yeah.
Yeah. Dr. Rajgopal Shenoy had a call from his hospital. He went there. That's why he is unable to speak now.
No, he has already sent a message to me. He has already sent a message to me. He's stuck in the hospital. Yeah.
Yes. So it was a nice PG clinics. The students have learned many things. And the moderator's approach was so nice. Exam nallo or hage ಏನಾದ್ರು ಕೊಡ್ತಾರೇನೋ ಇದೇ ತರ ಕ್ಲೂ ಕೊಡ್ತಾರೇನೋ ಅಂತ ಅನ್ಕೋತಾರೆ ಪಾಪ.
Vidyadhar sir,
you are guiding in the way. They should learn how to answer also.
With your permission, Vidyadhar sir has become very kind examiner.
Hello.
He was earlier he was ferocious. He's become, after retiring as examiner, has become a very kind examiner.
Hey, last year I had been to Ahmedabad, man, as a PG examiner. Last year.
Okay.
ಅದಕ್ಕೆ ಕೇಳ್ಕೊಂಡ್ರು ಅವರು ಯಾವ ಸ್ಟೂಡೆಂಟ್ ಅಂತ.
Hey, both of them are good.
Yes.
Okay.
Sir,
see you,
was
everybody.
Thank you, sir.
Very nice presentation, pages. And you know what are the things to upgrade yourself for the exam and for your future also, not for the exam. Don't prepare yourself for the exam, for your future. How to diagnose, how to move the patients, how to do the things also. And our examiners, Dr. Prabhakar and Dr. Chandrashekar and Dr. Mohan. It was very nice to hear your questions and the answers from the PGs also. And I thank all the participants of today's program. Thank you one and all, and good night. I thank our chairman in his absence, Dr. Rajgopal Shenoy also.
Thank
And
you.
Dr. Naaz.
Thank you so much.
Okay,
Thank you, sir. Thank you
all.
very much.
Good night.
Thank you.
Good night.
Good night.
Prabhakar, ಬೆಳಿಗ್ಗೆ ಬರ್ತೀರಲ್ವಾ?